Now the regulation of GFR, and the first thing is auto-regulation. In this diagram, you can see that between 80 mm of Hg to almost 180 mm of Hg of mean arterial pressure, renal plasma flow and GFR are not altered. Even though BP keep on increasing from 80 to 180, your GFR remain constant. It is called as auto-regulation, automatic regulation. Renal plasma flow is increasing, yes or no? No. Even though BP is increasing, but renal plasma flow, blood flow, GFR is not increasing. Why? Because there is a wonderful phenomena in the kidney, and that is called as auto-regulation. So the first factor for regulation of GFR is auto-regulation. Am I clear? In the auto-regulation, there are two mechanisms. One is myogenic, other is TGF. It is not KGF. It is TGF, Tubuloglomerular feedback mechanism. So coming to the first mechanism, myogenic. Myo means muscle. See, when lot of blood is coming from the afferent arteriole, suppose there is increased blood flow and lot of blood is coming from the afferent arteriole, there will be stretch in the afferent arteriole, and this stretch on the afferent arteriole will release calcium. This causes vasoconstriction, leading to decreased blood flow, like a Jaguar pump. If you put your hand, water will come. If you withdraw your hand, water will stop. Similarly, if more blood flow, constriction, less blood flow, dilation, automatic. So that blood flow should be limited. Suppose you are in anger mode and your BP is high, your kidney should not get more blood. That is your auto-regulation from 80 to 180 mm of Hg. So when there is more blood flow going to the afferent arteriole, stretch will cause calcium release, causing vasoconstriction, which decreases your blood flow, and this is called as myogenic mechanism of autoregulation. So here in the myogenic mechanism, the ligand is calcium. Then comes second is TGF, Tubuloglomerular feedback mechanism. Remember, it is TGF, not GTF. To differentiate this, I will discuss later on. But the regulation of GFR is done by TGF, not by GTF, not by glomerulotubular feedback mechanism. No, it is TGF, Tubuloglomerular feedback mechanism. Both are auto-regulation, myogenic as well as TGF. In TGF, the sensor is macula densa. Who is the sensor of TGF? Sensor of TGF is macula densa. Who is the sensor? Macula densa. Which channel is there? NKCC, sodium potassium 2 chloride channel. What it senses? What is sensed by this sensor, doctor? Some people say sodium. No, sodium as well as chloride. Where? In the thick ascending loop of Henle, in the DCT. Okay, in the DCT. So suppose there is more blood flows there. If there is more blood flow, macula densa will sense sodium and chloride and releases a ligand called as adenosine, which will cause vasoconstriction of afferent arteriole, will limit blood flow. So both are called as autoregulation. Only difference is that the mechanism. Both are working at which part of the nephron? They will ask you that autoregulation happen to work on which part of the nephron? The answer is afferent arteriole. It is the afferent arteriole where these are working, doctors. How they are working? And the myogenic, it is the muscles that are working. Calcium is the ligand. In TGF, macula densa is working by NKCC, and the ligand is adenosine. Both are causing vasoconstriction of the afferent arteriole. So these two mechanisms are called as auto-regulation, and I have told you earlier also, it is TGF, doctor, not KGF, okay, and not GTF also. So I am telling you GTF, but I am not telling what is GTF. GTF has nothing to do with the GFR regulation, but it is something else. Let me discuss here so that you should not get confused with the TGF. So what is GTF? Glomerulotubular feedback mechanism, or simply glomerulotubular balance. Suppose there is a condition when there is increase in the GFR. There is already more GFR is there. Okay, what will happen? You tell me. If there is more GFR, more plasma filter, then you want to reabsorb more water. Otherwise, water can be lost. This is your GTF. What is TGF? If there is more blood flow, you will cause constriction of the afferent arteriole. It is different thing. In the GTF, glomerulus will feel that GFR is more, please from the PCT reabsorb more water, otherwise you will lose water. This is your GTF. So whenever there is increase in the GFR, there is increase in the reabsorption of solute. This is called as glomerulotubular balance. And what is the mechanism? Now try to understand. If there is more GFR, more plasma flow, proteins are filtered or not? Proteins are not filtered. Even though there is more plasma filtration, proteins are not filtered. If proteins are not filtered, proteins will be accumulated in the glomerular capillary, in the peritubular capillary. So they will have more oncotic pressure, and in the PCT, they will absorb more and more water. Such a beautiful mechanism, automatic mechanism. It has nothing to do with the GFR regulation. I am just discussing here to differentiate between TGF. It is GTF. What is this? If there is more glomerular filtration, more proteins will be accumulated, and more proteins will increase more oncotic pressure. So more will be the water reabsorption. So write in the note that GTF is different than TGF. But in the regulation of GFR, you have to write number one, autoregulation. In the autoregulation, the first is myogenic and second is TGF, tubuloglomerular feedback mechanism. This is the first mechanism to regulate the GFR. Then the second mechanism, in the first chapter, I have discussed about the mesangial cell. They are present between endothelium and the basement membrane. They are also called as stellate cell. Stellate cells are similar to pericytes of the capillary, and they are contractile. And when they contract, they reduces the GFR. When they relax, they increases the GFR. So don't think they are of no use. They are very, very important. So mesangial cells have role in GFR, but in Viva sometimes they ask you, or in MCQ, what are the other function of this mesangial cell? Number one, they can secrete extracellular matrix. They can take up the antigen presenting cells also. They can proliferate also. They secrete biological active metabolites also. So they have role in glomerular disease, especially in immunological disease. So beside regulating GFR by causing contraction and relaxation, they have some other function as well. So now you know that if they contract, they will decrease the GFR. If they relax, they will increase the GFR. By this way, this is the second mechanism of regulation of GFR. But you must know what are the factors that can lead to contraction of mesangial cell and what are the factors that can lead to relaxation of the mesangial cell. So see the list. Angiotensin II will decrease the GFR by causing contraction of mesangial cell. Endothelin again can cause contraction. Norepinephrine, adenosine, thromboxane A2 and ADH. These are the factors which causes contraction of the mesangial cell and lead to decrease in the GFR. Now, the second list, what are the factors that increases GFR by causing relaxation of the mesangial cell? Very famous cyclic AMP, nitric oxide, atrial natriuretic polypeptide, dopamine, prostaglandin, they all causes increase in the GFR. Remember, plenty of time they will ask you, what are the factors that can increase GFR? There are various mechanisms. One of the mechanism is by causing relaxation of the mesangial cell. Dopamine, prostaglandins, atrial natriuretic peptide. The name suggests natriuresis, natriuretic peptide. The thing which is causing natri means sodium, uresis releases more sodium and water from the urine. It can happen only if there is more GFR. So this is the second mechanism by which your GFR can be regulated. Am I clear till now? Now coming to the third and the most important topic of the kidney. I don't know why, but teachers used to ask lots of questions from this topic. In one of the AIMS examination, 3 MCQ were only from this topic. In NEET PG examination, in your MBBS examination, in your Viva. The third is change in the resistance of afferent arteriole and efferent arteriole. So regulation of GFR by changing the resistance of afferent arteriole and the efferent arteriole. Each and every point is important. There can be 4 factors. Let me discuss one by one. Number 1 is constriction of the afferent arteriole. Who causes constriction of the afferent arteriole? Norepinephrine. I have discussed that earlier also. Afferent arteriole have receptor. Do you remember that? Yes, you remember that. So when there is a shock, when there is a hypovolemic shock, you want to reduce blood going to the kidney. You want to reduce renal plasma flow. You want to reduce GFR. Norepinephrine, especially during hypovolemic shock or during some other sympathetic stimulation, will decrease renal plasma flow as well as GFR by causing constriction of the afferent arteriole. Am I clear? So this will decrease both GFR as well as renal plasma flow. Number 1. Number 2, dilation of the afferent arteriole. It can be done by atrial natriuretic polypeptide, prostaglandins, dopamine. Isn't it? It is very simple. If you dilate the afferent arteriole, renal plasma flow and GFR both will be increased. So prostaglandin increases blood flow in the renal cortex. But remember one thing very important. Prostaglandin increases blood flow in the renal cortex but decreases blood flow in the renal medulla. This point is very important. Otherwise, in common, if they ask you about the afferent arteriole, they cause dilation of the afferent arteriole. Prostaglandins cause dilation of the afferent arteriole, increases your GFR, increases your renal blood flow. That is why NSAID, if someone is taking painkiller for multiple years, 10 years, 20 years, it can cause damage. Why? Because if someone takes NSAID, it inhibits prostaglandins. So it will cause constriction of the afferent arteriole because prostaglandins are needed to dilate. So GFR will be continuously decreased, renal plasma flow will be continuously decreased. So kidney can be deprived of the blood. It can be damaged. That is why ibuprofen damage, a lot of NSAID damage the kidney. This is the mechanism. Now the third and the most important, very, very, very important, constriction of the afferent arteriole. Angiotensin II can cause constriction of the both efferent arteriole and afferent arteriole, but mainly it causes constriction of the efferent arteriole. Now this is very important. Sometimes 2-3 questions in one examination only on this constriction of the efferent arteriole. What is going to happen? Now this is afferent arteriole, this is efferent arteriole. If there is constriction of the efferent arteriole, what will happen to the GFR? If there is constriction of the efferent arteriole, don't you think GFR will increase due to increase in hydrostatic pressure? Yes. So there will be increase in the GFR due to increase in the hydrostatic pressure. Yes. First point. So can constriction of efferent arteriole, can it increase the GFR, doctor? Yes. How? By increasing the hydrostatic pressure. Now just imagine, if you continuously constrict efferent arteriole, moderate to severe, the backflow pressure will decrease renal plasma flow. Yes or no? If there is a continuous constriction of the efferent arteriole, because of the backflow, renal plasma flow will be reduced. Yes. So don't you think GFR will also be reduced? Yes. When blood itself is not coming, how can GFR will be there? So now GFR will be low. This is the trick. This is a very interesting. They will ask you, doctor, tell me, constriction of the efferent arteriole will increase the GFR, will decrease the GFR. You can say both. It can cause both. Then they will ask you, okay, doctor, it can increase the GFR due to. Okay, answer is increase in the hydrostatic pressure. It can decrease GFR due to decrease in the renal plasma flow. Assertion reason type of question. GFR increases during constriction of efferent arteriole due to increase in what? Renal plasma flow or hydrostatic pressure? Hydrostatic pressure. Sometimes they ask you assertion reason type of question. Assertion is correct, reason is correct, but reason is correct for assertion or not, like this. So if your concept is clear, you can solve any type of question. Listen carefully once again. If there is constriction of the efferent arteriole, doctor, tell me one thing, hydrostatic pressure will increase or not? Yes. And this can lead to increase in the GFR. And because if there is constriction of the efferent arteriole, because of the back pressure, renal plasma flow will decrease. So GFR can also decrease. So first GFR will increase and then GFR will decrease. Point number 3. What is going to happen to filtration fraction? What is filtration fraction, doctor? It is GFR upon renal plasma flow. GFR increase and then decrease, but renal plasma flow always decrease. So if denominator is less, end result will be high. So filtration fraction will be more. So during constriction of the efferent arteriole, filtration fraction is always more. This point clear? Third point. Point number 4. If there is more filtration, don't you think proteins will be accumulated in the glomerular capillary? Yes. So if proteins are accumulated, oncotic pressure will be more. Yes. So that is why, doctor, during constriction of efferent arteriole, proteins will be accumulated, oncotic pressure will be high. Yes or no? Yes. These points need to be remembered. Let me discuss one by one again. During constriction of efferent arteriole, GFR will be high due to increase in the hydrostatic pressure. Then GFR will be low due to decrease in the renal plasma flow. Filtration fraction will be always high because of decrease in the renal plasma flow, and because if there is more protein accumulation, oncotic pressure of the glomerular capillary will always be high. Believe me, each and every word is like a gem. Almost everything has been asked in your examination and clinically very relevant. Okay. Now the fourth point is dilation of the efferent arteriole, reducing the resistance of the efferent arteriole. Now angiotensin II is causing constriction of the efferent arteriole. So who will cause dilation of the efferent arteriole? ARB. What is ARB? Angiotensin II receptor blocker drug, like sartans. Tell me sartan, olmesartan, all the sartan drug, they are working on angiotensin II receptor. So dilation of the efferent arteriole is caused by ARB. It will decrease the GFR and increase renal plasma flow. It will decrease the GFR because hydrostatic pressure is low, and it will increase renal plasma flow, doctor. Now ARBs are good for the kidney. Why? See, suppose that if someone is having a viral infection, we say take more and more nutritious food, fruits, and rest. So if kidney is resting, renal plasma flow is high, getting more oxygen, and GFR is low, functioning is less. So you are giving rest to the kidney. That is why ARBs are nephroprotective drug. These are good drug for the kidney.